Hello and good morning, good afternoon, good evening. My name is Glenn Pierce. I am the Vice President for Medical for the World Federation of Hemophilia. And on behalf of my colleagues, it's our pleasure to welcome you to this webinar on COVID-19 treatment and vaccination for people with bleeding disorders around the world. We have an ambitious agenda with speakers who are going to review many aspects of COVID. I'll go over that in a moment. But I would first like to introduce our president, Cesar Garrido. He's the president of the World Federation of Hemophilia, was elected last fall, and he would like to make a few opening remarks. Cesar?
Thank you, Glenn. Well, good morning, good afternoon, good evening, depending where you are. So Glenn said, I greet all of those attending this webinar related to a topic so present among us today, COVID-19 pandemic. I want to convey tranquility and confidence to you. I know that many have doubts, concerns, uncertainty, and it's absolutely normal. The reason is because for all of us, what is happening to us is new, and we are just learning. You and I are lucky because we have someone to ask. We have some health professionals who are watching over all of us. The World Federation of Hemophilia has been able to overcome major complications, and we will overcome this one as well. So let us take this opportunity and learn so that we feel more confident and defeat this enemy that we had not considered. Thank you. Enjoy the webinar.
Thank you very much, Cesar. What I'd like to do is I would like to first go over a little bit of housekeeping, and then I will review the agenda. If I could have the housekeeping slides, please. And so for those of you who are on either computers or phones, we're going to have simultaneous interpretation in Spanish, French, Arabic, and Russian. And if you're using your computer or a tablet, please click on the interpretation button at the bottom of the screen to select your language. If you're on a mobile phone, there's some additional steps that you need to do. If you can give me the next slide, yes. The image on the left shows an Android phone, and there's 3 dots to select the interpretation channel, as you can see at the bottom of the screen. And the image at the center also then shows an iPhone. Select the interpretation, the language interpretation option there, and make sure you click on Done at the top of the screen to be able to select your language correctly. Next slide, please. Following today's webinar, we would like to encourage you to visit additional COVID-19 information on the WFH website, and we have given you 2 URLs in order to access those. We also have just published in the journal Hemophilia a list of vaccination components that are important for individuals with bleeding disorders that was written with many of us from the Blood Plasma and Blood Safety Committee, but also led by Radek, who will give a talk on this. So we would encourage you to take a more detailed look at that. And then finally, on the next slide, we have additional information on the WFH website, resources and tools, including the WFH guidelines for the management of hemophilia. And we would encourage you to be able to access and download that. We will start with a refresher on COVID-19. We'll move to the epidemiology of COVID-19 within bleeding disorders and some of the unique components of bleeding disorders and COVID-19 infection. And then we're going to hear about the COVID variants and get some perspectives from South Africa on their variant, as well as a number of other variants that have appeared around the world. We'll then move directly into what I was just referring to, guidance for people with bleeding disorders, on the COVID-19 vaccines, and how to use those appropriately in individuals with bleeding disorders. And then we have a special guest from the WHO who will provide an update on the allocation of COVID-19 vaccines around the world. If I could go to the speakers, please. These are our speakers, and I've already introduced myself. I'd like to introduce Miguel Escobar, who will be our first speaker. Miguel is Professor of Internal Medicine and Pediatrics at the Gulf States Hemophilia and Thrombophilia Center at the University of Texas in Houston. He's also the Director of Clinical Research there. He is a board member of the WFH. Cedric Hermans is also a board member of the WFH, and he heads the Division of Hematology, Hemostasis, and Thrombosis Unit, as well as the Hemophilia Center at the St. Luke University Hospital in Brussels, Belgium. He's a professor, he's a prolific author, has written much in the area of clinical research in hemophilia, is also the editor-in-chief of the Hemophilia Journal. And then Professor Johnny Malangu is at the University of Witwatersrand in South Africa, in Johannesburg, and heads the National Health Laboratory Service. He's also the head of the School of Pathology at the university. And Johnny is well known as a clinical trialist who has spearheaded a number of clinical trials on innovative agents in the area of hemophilia. And then Dr. Radek Kaczmarek is at the Indiana University School of Medicine in Indianapolis, Indiana, where he is working on gene and cell therapy programs and projects. And Radek is also the chair of our Coagulation Products Safety, Supply, and Access Committee for the World Federation of Hemophilia. And our final speaker, who will be speaking on COVID-19 vaccine access, is Iona Giga, who's a technical officer with the WHO Global Infectious Hazard Preparedness Department in the WHO Health Emergencies Program. And at the WHO, she's managed a variety of different projects on aspects related to allocation, deployment, country capacity building for the pandemic influenza vaccines, and is well prepared then to be able to be involved in the COVID-19 vaccine rollout. She has a lot of experience in vaccine trials and in vaccine access, both with the RAND Corporation as well as with the WHO, and has been actively involved in the access to vaccines in a variety of different income level countries, including low and low middle income countries. So we welcome her as well. With that, I'd like to turn it over to Miguel to give us our first talk, which will be on coronavirus, what you need to know. Miguel, please take it away.
All right, thank you, Glenn. Well, it's a pleasure to be able to provide this information. Next slide. So what I'm going to do is, again, give you just an overview of what we know so far. And first of all, I'd like to clarify certainly some of the terms. First of all, we know that COVID-19 is a newly identified strain of the family of viruses called coronavirus. We do know other coronaviruses. So some of you might be familiar. Remember, in 2003, we had the SARS, which is the severe acute respiratory syndrome. And in 2012, we had the MERS, which is the Middle East respiratory syndrome. Next. So you guys are familiar with the terms coronavirus, COVID-19, SARS, but while this infection is being called coronavirus, the official name is actually COVID-19 or SARS-CoV-2, which stands for severe acute respiratory syndrome coronavirus 2. So those two terms are pretty much the same. Next one. So where did this virus come from? Well, based on the data that is available, we know that in early December of 2019, there was the first pneumonia cases that originated in China in the city of Wuhan. And then from there on, it seems like, certainly it was spread all over the world. The first case that was reported in the US was confirmed in January of 2020. Next slide. Now, it's interesting that I gave a talk on COVID about a year ago. This was in in April. And we can see here the total cases that we had at least reported in the world was 1.3 million with 74,000 deaths. Now today, next slide, we have a total of 117 million cases just in a year with over 2.5 million deaths. So you can see here the spread of this virus that has been pretty much, I think, affected every single country in the world. Next slide. So who are the people that get mostly affected? And the infection, as you can see, is widespread, but there are certain categories, certain individuals that are probably more prone to getting sick or getting hospitalized. And you can see this is a very recent graph that comes from the US. And we see that actually the group that has the older age, older than 65, which is the red curve, are probably the individuals that are getting mostly admitted. And unfortunately is the group that is having higher mortality. Then comes the group from the 50 to 64 and they're on. You can see the children are very rarely have severe disease or, they are affected from this infection. Next slide. So how do we get infected? We already know now that the virus spreads mainly from person to person. So usually being in close contact. And that's why the guidelines talk about having at least the 6 feet or the 1 meter, separation, through body fluids. This could also be happen. It's very easy when somebody sneezes, somebody coughs, even talking, singing. I mean, it's enough to be able to spread these viruses. Now, the other way that could be spread is, through the surfaces, touching surfaces that might be infected. There is pre-symptomatic transmission, meaning that many people have no symptoms and can still have the infection and spread it or pass it on to other individuals. Next slide. So it can be passed on. Again, the main way to do it is through droplets. And again, is because it comes from the surfaces on the mouth and the nose, or it can be from aerosols as well. So if you're in a close encounter, let's say in a room, potentially there could be these aerosols around that could still be circulating, and you might be more than 6 feet apart, but you can still get infected. Those individuals, one individual is infected or they don't have a mask, is that possibility. And again, as I mentioned, also through the different surfaces is also a way that people can get infected. The main infection is through droplets or aerosols. Next slide. So what is the population at risk? Where are the individuals that we've seen that getting mostly infected or that are getting extremely sick? So it's the older population, as I show in that graph. Immunocompromised individuals are also people that are at high risk of having severe infection. People with underlying respiratory conditions like COPD, asthma, patients with diabetes, with hypertension, cancer, chronic kidney disease, and obesity. Obesity seems to be a high risk for people could get severely ill from an infection with COVID-19. Next slide. So what are the symptoms of COVID-19? Remember that symptoms can appear anywhere from 2 to 14 days after being exposed to the virus. So you can still be infected. You might not have symptoms. It might take a while, but you could still be transmitting. One of the most common things is loss of taste or smell, but people can present different ways. Some individuals have only had a headache and some, like general aches. Some have fever, chills. Others can have cough, sore throat. Some patients might present with shortness of breath. And, some patients might have presented as well with some GI illness like diarrhea. Next slide. Now, COVID-19 could affect any organ, and these usually happens when patients get admitted and become severely ill. It can affect the brain, it can affect the kidneys, the liver, the GI tract, the heart. It can affect the pancreas. Even patients present sometimes with skin changes. But many patients that get very ill will develop thrombosis and mostly affecting the lungs, but it can also affect some of the other organs or some of the vessels as well. Next slide. So when do you want to seek medical attention? Well, it's important always when you have symptoms, talk to your doctor first. Explain what is happening here. Most patients are going to have mild symptoms and they will recover at home, with just some fluids, some rest. That is enough to be able to have no complications. But you got to be aware of some of the emergency signs, that you need to seek medical attention to see your doctor or go to an emergency room. And these include having trouble breathing, pressure in your chest, being confused or having changes in the color of your skin or your lips. Next slide. So what can we do to avoid getting infected? You know, there are many guidelines out there, but the main things are going to be what I call the 3 W's, you know, wear, wait, and wash. You have to wear a mask. It's the best way to prevent infection right now, and make sure that mask is covering your nose and your mouth as well. Wait, stay always 6 feet apart, you know, try to keep that distancing from other individuals, and wash your hands well with soap and water or a hand sanitizer. Those are going to be the best ways to avoid getting infected. Next slide. The other question is, should I get tested? You know, not everybody needs to get tested. Most people, as I said, have mild symptoms and can recover at home. But if you have symptoms of COVID, you know, like I said, talk to your doctor first. There are different indications when you need to be tested. I mean, certainly if you need to go to work, if you, you know, have to go to school, I mean, they're all guidelines that are differently now being posted in, depending on the country, under your institution, but always try to talk to your doctor first. Next slide. Right, that's all I have right now in terms of a general overview of COVID-19. Thank you.
Thank you. My name is Cedric Hermans, and it's a great pleasure to share with you some data about the epidemiology of COVID-19 in patients with inherited bleeding diseases. Next. So there are several questions that could be raised. The first one is how many patients with inherited bleeding disease develop COVID-19 in the different parts of the world. Another one is whether the incidence is different compared to the general population. And also, when patients with inherited bleeding disease develop COVID-19, how many in fact do require hospital admission, transfer in intensive care, assisted ventilation, and what is their clinical outcome? Next. So what source of data, what evidence is currently available? First of all, we have some data in the international literature. There are also many registries that have been launched over the last year, and some of them already provide interesting results. I will share with you some of the results that have been accumulated in one of these registries, and also our personal experience here in Brussels, in Belgium. Next. So if you look at the literature, well, there are some data that have been published, and I'm quickly sharing some of the data with you today. So we have data from Iran, where a large study, and they concluded that the incidence and the prevalence of COVID-19 was in fact even lower in patients with inherited bleeding disease compared to the general population. You can see some figures on the slide. And the mortality rate in the infected general population was around 5%, and it was 0 in that Iranian cohort. We also have some data from China, but in that study, they compared the impact of the COVID pandemic on the population of patients with inherited bleeding disorders in 2 cities, but no epidemiological data were provided. We also have nice data coming from Madrid, where a large population of patients with hemophilia and other bleeding disease is currently followed, and they identified 42 patients with symptoms suggestive of COVID-19. The RT-PCR was positive in 6 of them, and the cumulative incidence was found to be 1.7%. Next. We also have data from this ADVANCE study. So the ADVANCE initiative is a large initiative that was launched a few years ago with the support of a pharma company, Bayer, and clearly the purpose was to look at the epidemiology, diagnosis, and management of different comorbidities in older patients with hemophilia above the age of 40 across Europe. And we decided a few months ago to focus part of this initiative on COVID-19. So we try to compare the rate of infection and outcome between the national hemophilia and the non-hemophilia population within the advanced represented countries. And we looked at specific issues. I don't have much time to go into the details of this, but clearly that cohort does focus on patients who are more than 40 years of age with hemophilia A or B. This is a retrospective and prospective study that is currently still ongoing. And you can see here, you know, the study design. with a retrospective part between March and November 2020, and a prospective part that was initiated in December. Next. So this slide shows you that, in fact, many European centers are taking part in this advanced project. So we have 25 centers, 16 countries, close to 4,000 patients with hemophilia. And we are currently trying to collect data in all these centers about the impact of COVID-19 on our hemophilia patients. Next. And here you can see some of the very preliminary data. So on the left part of the slide, you can see the total number of patients with hemophilia A and B above the age of 40, so close to 4,000. And on the right part of the slide, you can see that, in fact, in November 2020, we could only identify 5 patients who had to be admitted in hospital. And on the lower part of the slide, you could see that 19 patients with hemophilia A or B had been diagnosed with COVID-19. So quite small numbers. It's clear in my view that if we repeat the survey today, these figures would be certainly a bit higher. Next. And I can also share with you some of our local data here in Brussels. In my HTC, we're currently following approximately 250 patients with hemophilia A and B, and more than 100 of them are older than 50. And until now, we have had 10 patients identified formally with COVID-19. 3 had to be admitted in hospital. All of them were older than 50. And why require ICU admission, ventilation, and 2 did not require this. But maybe let's move to the next slide to show you what are the main characteristics of these 3 patients who were admitted in my hospital. So the first one is the 54-year-old gentleman with severe hemophilia A, but with multiple comorbidities, was on AHL factor 8, required admission in ICU, ventilation, and unfortunately died. And you need to know that the post-mortem examination did not reveal thrombotic, at least macroscopic thrombosis or bleeding complications. We also had another patient, 65 years of age, with severe hemophilia B, no comorbidities, and who had been cured by gene therapy in November 2019, no ICU admission, and this gentleman survived. And more recently, we had another case, a gentleman of 80 years of age with severe hemophilia A and multiple problems, including factor V Leiden, atrial fibrillation, who is on emicizumab and was treated on the ward, did not require ICU admission, and survived all this. And I met him yesterday, and he's doing perfectly well. Next slide. So in terms of epidemiology, I would like to conclude by saying that currently we have limited data available on demography of COVID-19, but many registries are currently collecting data, and these data are not yet in the public domain, but I'm confident that this data will be released very soon. So several ongoing registries, and the available data and also my personal experience do not support that the demography of COVID-19 is different in patients with inherited bleeding disease compared to the general population. I thank you here for your attention.
It's an absolute pleasure to join you this afternoon, South African time, and I'm sure it's afternoon and morning somewhere else, to talk about the COVID-19 variants giving a South African perspective. My name is Johnny Mahlangu. I'm a hematologist based at the Charlotte Maxeke Johannesburg Academic Hospital in Johannesburg. Next slide, please. This slide shows my conflict of interest disclosures, just outlining my interface with clinical trial partners. Next slide, please. The agenda in the next 10 minutes is a fairly straightforward one. I just want to perhaps outline what we know about COVID-19 variants, the implications of having COVID-19 variants on vaccine development very briefly, specifically honed down to the B1351 variant lab and clinical data. This is the South African version, and then I will give you my concluding remarks. Next slide, please. The question that is commonly asked by many people, lay people and professionals, is, are viruses living organisms? And perhaps before I answer that question, is just to remind you that COVID-19 actually comprises of two components. One is nucleic acid, which is a single-stranded RNA, and the other is the envelope protein that surrounds the nucleic acid. Perhaps to note that there is obviously a variety of proteins that are encompassing the nucleic acid, including the spike protein, the membrane protein, the small envelope proteins, and many others. What is noteworthy, of course, is that the virus is incapable of independent existence. So it does require a host to survive. And to some extent, in fact, that answers the question, are viruses living organisms? The answer is probably not. They are only living organisms when they are in another living organisms. What is also noteworthy is that our own genome, the human genome, has viral sequences which we acquired over the years. These are luckily integrated and they are not actually viruses that are alive. Up to about 8% of the human genome has now been characterized as having viral sequences. And you could ask, what is the main function of a virus? It would seem that its main function, it exists to replicate itself. Next slide, please. The reason the viral variants will develop is that as part of that replication in living cells, the virus will harness two components. One is the host energy, and the second one is the machinery that the host has in order to replicate itself. And in the sort of normal dogma from the RNA that the virus has got, you can then get messenger RNA, which is translated into viral proteins. These viral proteins, obviously, they are part of the viral particles. It is through this process that there are replication errors. And it is these replication errors that give rise to the viral variants. And one of the reasons why there are replication errors is because unlike DNA organisms, viruses have got what we call RNA polymerase, which does not repair itself. And that is the reason why the replication errors creep in during the replication process. The survival of the viral variants depends largely on the environment in which they find themselves, and of course the selection and the pressure under which they survive. Next slide, please. Just want to remind you that both in the scientific literature and in the lay press, we hear all the time about variants. There are many of these. Some of you might have heard about the UK variant, the so-called B117, the South African variant, the B1351, the Brazilian variant, P1, also identified for the first time in Japan before it was identified in Brazil, and many other variants, some in the US, in Nigeria, in Australia, and many more, in fact, in the UK. What is noteworthy with these variants is that they've got common mutations, such as the E484K, the N501Y, and of course, some of them are very unique with different mutations that are not common. We are particularly interested in these mutations. Next slide, please. Because we'd like to believe that some of these mutations may confer certain clinical features in the viruses. For example, if one looks at the E484K mutation, we do know that it is associated with the survival of the virus. So we do know that, in fact, it is an escape mutation. There are many other escape mutations, such as the N501Y, and the L452R. The other mutations may increase the ability of the virus to bind to the receptor. Its natural receptor is the ACE2 receptor in the lungs. This will include the 614 and the 681 mutations. which are found in the variants. Next slide, please. We also know that not all viruses, viral mutations are of interest. Some, of course, are of interest, some are of concern. The ones that have been characterized as variants of concern are the three that I've listed here, the B117, 351, as well as the P1. And the reason they are actually of concern is because they do have a change in the epidemiology of the COVID-19 disease. If you look at the B117, we do know that its ability to transmit is increased by 46 to 72% when you are infected with this variant compared to the original COVID-19 virus. If you look at the B1351, the South African variant, we've now characterized this variant as having higher viral load when compared to the original COVID-19 virus. And then when one looks at the P1 variant, the Brazilian variant, we do know that there has been cases reported where individuals have been infected more than once with the same virus, which is unique, obviously, to this virus, but something that luckily we have not seen in other viruses. Next slide, please. Next slide. So the big question I think we should be asking ourselves is, given that we do have the variants, which of the vaccines will be effective against the different variants? And it is in this context that I specifically want to talk about the B1351, the South African variant, in relation to the various classes of vaccines that we have. If you first look at the messenger RNA vaccines, that is the Pfizer and the Moderna vaccine, we can see that in fact they appear to be effective against the B1351 variant. If you look at the second class of vaccines, these are the inactivated vaccines represented here by the Sinopharm vaccine. There seem to be reduced neutralization of this particular variant by the inactivated vaccines. If you look at the protein subunit vaccines represented by the Novavax, we also see that there is reduced efficacy in neutralizing the B1351 variant. As an example, the efficacy in the UK is 89%, whereas the Novavax in South Africa is 49%, which is clearly a reduction in the efficacy. And finally, if one looks at the new generation of the vaccines, the so-called viral vector vaccine represented by the AstraZeneca and the Johnson & Johnson, we see a similar picture of reduction in efficacy in neutralizing the B1351 virus vector. Next slide, please. So if one looks at the in vitro data in relation to the B1351 vaccine, the picture is beginning to emerge that in fact the majority of these vaccines are very much ineffective against this variant. If you look at the AstraZeneca vaccine, the reduction in efficacy is as low as 3% and as high as 86-fold when it is directed to the B1351. We don't have data on the Johnson & Johnson vaccine efficacy in vitro on the B1351. If you look at the Moderna, as well as the Pfizer and the Sinopharm, you can see that in fact there is a reduction in their efficacy when they are used in vitro against the B1351. We don't have the data on the Novavax vaccine. Next slide, please. So what about the clinical data? The clinical efficacy of some of these vaccines against the B1351 variant have now emerged, and they are available in the public domain. And of course, it's important to separate mild and moderate COVID-19 disease from severe disease that may well lead to hospitalization and death. So if we take the mild and the moderate disease, we've got 22% efficacy on the AstraZeneca vaccine, 57% efficacy with the Johnson & Johnson vaccine, and 49% with the Novavax vaccine. If one looks at the severe disease, it would seem that the only data that we've got is the Johnson & Johnson data, which showed an 85% efficacy. The other data is still evolving, and certainly this data will be available in the future. But I mean, if you wondered why the South African community decided to abandon the AstraZeneca vaccine consignment that is currently in South Africa and start to vaccinate with the Johnson & Johnson, it was largely informed by this data set, the clinical data set. And most of us, in fact, think that the picture may well change as the data set from the other vaccines become available. Next slide, please. So if I were to conclude, I think I've shown you very limited data on the lab studies that have been undertaken in establishing efficacy of the various vaccines against the B1351 variant, which is the South African variant. From this data, in fact, one could deduce the clinical studies have shown efficacy against mild and moderate COVID-19 disease, demonstrated by the AstraZeneca, the Novavax, and the Johnson & Johnson vaccines. We do not have data on the Pfizer, Sinopharm, and the Gamaleya vaccines. If one looks at severe disease and hospitalization, the only one that has shown efficacy of 85% is the Johnson & Johnson against the B1351. We do not as yet have data on the other vaccines. And in conclusion, I would like to perhaps leave you with a thought, the thought that maybe we should be thinking about how to think about sustainable vaccine program around the world, and in particular in countries like South Africa. In addition to safety elements, efficacy elements, which are very important, in the current economic climate, one is obliged to think about the cost of the vaccine, the ease with which the vaccine can be stored or administered, and perhaps more importantly, whether one needs a vaccine that can be given as a single dose or as multiple dose. I will stop there and hand over to Radek for the next presentation. And thank you very much for your attention.
Thank you, Johnny. Hello, everyone. My name's Radek Kazmarek. I am the chair of the Coagulation Product Safety, Supply and Access Committee of the World Federation of Hemophilia. It is my pleasure to take you through this guidance today, which we hope will be helpful for both people with bleeding disorders and healthcare providers. Next, please. So specifically, I am going to give you an overview of recommendations just published in the journal Hemophilia in the article entitled Vaccination against COVID-19, Rationale, Modalities, and Precautions for Patients with Hemophilia and Other Inherited Bleeding Disorders. These recommendations have been formulated by members of the Coagulation Product Safety, Supply and Access Committee on behalf of the WFH, the European Hemophilia Consortium, the National Hemophilia Foundation, and the European Association for Hemophilia and Allied Disorders. Next, please. We have a long way to go before we can end the COVID-19 pandemic. As of a couple of days ago, nearly 118 million individuals have been infected with the SARS-CoV-2 virus, more than 2.6 million of whom died. And globally, the infections are still running rampant. So the only reasonable way to put an end to this is carrying out efficient vaccination campaigns to limit the spread of the virus. Next, please. Many individuals have concerns about vaccination. Some are legitimate, the others are entirely fueled by misinformation. So let's have a look at the facts. Next, please. First and foremost, vaccines work and they are safe, at least to the most common variants. This has been demonstrated in tens of thousands of individuals in clinical trials and continues to show post-approval. Vaccines provide protection from infection with the virus. They achieve this by prompting the immune system to develop protective antibodies against the virus and generate immunological memory, which ensures long-lasting protection from infection. And next. Individuals with COVID-19 mount the same or a similar kind of protective response to the virus, but potentially at the cost of severe or fatal complications, about which you heard from previous presentations, so I'll not go into the details here. Next. If you take a closer look at what exactly vaccination does, it exposes the immune system to important structural proteins of the virus. This can be achieved by administering recombinant viral proteins or genetic information encoding those proteins called messenger RNA or mRNA, or a harmless virus engineered to encode proteins of the target virus in this case being SARS-CoV-2. So the first two approved vaccines are mRNA vaccines. These vaccines stirred a lot of controversy, so I'll take a moment to say a little more about them. What they do is they deliver the mRNA encoding a viral protein to the cells of the vaccinated individual and instruct those cells to produce that protein, which they do, and then they display that protein to the immune system, which recognizes it as foreign and produces a response. Now, prompting the cells to produce viral proteins in this way mimics what the virus does in the course of natural infection to replicate itself, but without causing morbidity. The mRNA technology used to manufacture these vaccines has been studied for more than a decade, so this technology is not that new. And the past research has remarkably helped to speed up the vaccine development. The bottom line is that all the approved COVID-19 vaccines have shown safety and effectiveness. Next. Moving on to specific recommendations for people with bleeding disorders. These individuals are not at greater risk of getting infected or developing severe COVID-19. Consequently, they are not considered a priority group for vaccination. However, when they do develop the disease and require hospital admission, their management may be very complex, which should be a strong argument in favor of vaccinating. Also, a bleeding disorder should not be the sole reason to deny vaccination to anybody. Next. There is currently no reason to prefer or avoid a particular type of vaccine for people with bleeding disorders. Several vaccines use an adenovirus. That may sound familiar too and perhaps raise red flags with people interested in gene therapy, but it is important to understand that adenovirus is not related to adeno-associated viruses or AAV. These are different viruses, and adenovirus is not being used in hemophilia gene therapy. So people with bleeding disorders can be vaccinated with adenovirus based vaccines without worrying about their eligibility for gene therapy. Also, no vaccines against COVID-19 use AAV viruses at this point. If AAV-based vaccines are available in the future, people with bleeding disorders who are considering AAV gene therapy should avoid them because this type of virus is widely used as a vector for gene therapy, and prior immunization against AAV with an AAV-based vaccine could make them ineligible for gene therapy. Next. The vaccines should be administered intramuscularly. Effectiveness of vaccines against COVID-19 has been demonstrated only with intramuscular delivery, so they should not be administered via other routes, for example, subcutaneously. To minimize the risk of bleeding, individuals may require hemostatic treatment prior to intramuscular injection, and I will cover that in more detail in a moment. If possible, the smallest gauge needle available should be used for intramuscular injection. However, some vaccines must be administered using the accompanying needle-syringe combination to ensure integrity of nanoparticles. Discomfort in the arm felt for 1-2 days after injection should not be alarming unless it worsens and is accompanied by swelling. Any adverse events should be reported to a hemophilia treatment center. Next. Allergic reactions require immediate medical attention as they may be life-threatening. Patients with a history of allergic reactions to extended half-life clotting factor concentrates containing polyethylene glycol, or PEG, should discuss vaccine choice with their physician because some vaccines contain PEG as an excipient. Also, people with bleeding disorders who have had a history of allergic reactions to blood products, including factor concentrates, plasma, and cryoprecipitate, but have not had reactions to previous vaccines, are not at greater risk than the overall population for a reaction to a COVID-19 vaccine. Next. The WFH is aware that many people with bleeding disorders globally have limited access to hemostatic therapies. Those individuals may seek access to the WFH humanitarian aid program, which could provide treatment to minimize the risk of bleeding following an intramuscular injection. Next. Patients with severe or moderate hemophilia or type 3 von Willebrand disease should receive factor concentrate on the day of vaccination and before the intramuscular injection to prevent bleeding in the muscle. There is no evidence that vaccination increases the risk of inhibitor formation. So clotting factor administration should not be staggered or delayed. There have been research and there have been suggestions in the past about the potential impact of vaccination concomitant with factor administration on inhibitor development. However, this has not been confirmed clinically so far, so should not be used for decision making. Next, please. Patients on emicizumab or those with factor VIII levels higher than 10% do not need extra hemostatic protection prior to vaccination. Patients with type 1 or 2 von Willebrand disease may need therapies and should consult their treatment centers. All rare bleeding disorder patients should be vaccinated, and their hemostatic support would depend on the severity of the disorder and should be decided in consultation with their treatment center. Next. There are no specific contraindications to vaccination related to complications of bleeding disorders or their therapies. So people with bleeding disorders undergoing immune tolerance therapy or treatment for hepatitis C or HIV infection or other conditions can be vaccinated. Regulatory agencies have published specific advisories for people with a history of allergic reactions. Specifically to previous vaccinations. Other potential contraindications should be discussed individually with the physician because recommendations vary in different geographies. Next. Vaccination is not contraindicated for patients on immunosuppressive agents, but their immune responses and protection from infection may be reduced. Next. Patients taking part in a clinical study should discuss and report vaccination to the study investigators. Next. And finally, it is important that hemophilia treatment centers, in close collaboration with patient organizations, take action to inform patients about the vaccines and contribute to an effective vaccination program. Next. In conclusion, vaccines against COVID-19 are safe and effective in preventing infection. People with bleeding disorders should be vaccinated just like the rest of the population. The success of the fight against the pandemic will depend on expeditious vaccination of the largest possible number of well-informed individuals worldwide. Thank you for your attention, and it is my pleasure to hand over to the next speaker.
Thank you very much, Radek. And first of all, I would like to express my appreciation to the organizers for inviting WHO to present this update and really be part of this important event. It has been a real treat and pleasure to listen to all the eloquent presentations so far. And so thank you for having me here. And also, I have to present my apologies for my voice. It's been a bit tricky today. Next slide, please. In this presentation, I will give you a bit of an overview on the global approach to allocation of COVID-19 products through the global mechanism. Tell you how things have developed, but also give you an update on the latest allocation rounds, and also flag some resources where you can go and find more information and read more, as well as track progress following this seminar. Next, please. So we have already heard about the epidemiology of the disease, and we are seeing that it has affected a lot of countries around the world, regardless of income level. And really, I should have put here an epi curve. But what I wanted to say is that we have been seeing lately a decreasing trend. However, we need to remain cautious about interpreting this. And while now vaccines are available and the rollout is unfolding, we are still in the beginning of the end. So it's important not to leave our guard down, and to remain vigilant, and to apply the measures that have been recommended. Next, please. So on the vaccines, it has been a great achievement for the scientific community to develop these medical countermeasures, considering that we are dealing with a novel pathogen. So this has been a quick development, and it's important to celebrate the fact that we have them. However, we are still in a situation where supply is limited and there is high demand for these medical countermeasures. And this has been anticipated ever since the pandemic started. And that's why it was considered that a coordinated approach will be needed to ensure equitable access of these vaccines for all countries. The products themselves, of course, need to be of high quality, efficacy, and have high safety standards. And maybe some of you are familiar with the WHO pre-qualification program. This is a program that has been around since the 80s, if I'm not mistaken, and especially products that are distributed through procurement agencies such as UNICEF Supply Division and PAHO Revolving Fund. They need to have this stamp of quality. So it consists of a review of several elements, and then certifying that the standard qualities have been met. And the WHO emergency use listing procedure is linked to this, but it is done for emergency situations, and where products can receive a WHO EUL. And as data continue to gather, then the full PQ is assessed. So to date, we have 3 products that have undergone this procedure, the WHO emergency use listing. And these are the Pfizer-BioNTech product and the AstraZeneca ones that are being produced in 2 different places. One is the Serum Institute of India, and the other one is SK Bio in Korea. And yesterday, the Johnson & Johnson product has been approved by EMA, and shortly we expect that next week it will also receive, or it will the WHO emergency use listing team will also have an opinion on this. Next slide, please. Okay. So if we go back now to the global allocation, we need to remember that getting these vaccines to populations in need is not only the right thing, the moral thing to do, but also the smart thing. The public health impact cannot be achieved in isolation. Every country is, these viruses know no border, and I'm sure you have heard this so much that you are saturated by this expression, but it is the truth. And it's also important to note that there is an economic impact associated with the pandemics in general. And lately there have been some studies which have also put a number actually on what would happen if some countries vaccinate their citizens while others are left behind. And you can go into the link and check some of the studies that have been done. And next, please. So recognizing that there needs to be this coordinated approach, in April 2020, the world community in a way has come together, and they have articulated the ACT Accelerator, which is a global mechanism that aimed to advance the development of medical countermeasures, and also help with the distribution of these products. So if you look at this figure, which I realize now is very small, you can see some vertical pillars, and they correspond to the type of product. So they can be vaccines, diagnostics, and therapeutics. And then at the bottom, it's a sort of transversal pillar, which is called the health system connector, and the activities around that area is to make sure that these products can be distributed and absorbed and not be wasted. So this whole effort has brought together a series of stakeholders from government, scientists, civil society, philanthropy. So it's really has leveraged a lot of networks and strengths of different stakeholders. And in particular for vaccines for 2021, the goal is to distribute 2 billion doses, with the hope that this will put an end to the acute phase of the pandemic. So next slide, please. So now if we delve in a bit more into the vaccine pillar, one aspect of it was to establish what is referred to as the COVAX facility. And this is a mechanism that wants and aims to facilitate access to vaccines for all participating countries, and it is open to all countries around the world, regardless of income levels. And to date, this community has managed to bring together 191 donors, participants that pay for the vaccine, and also participants that are supported financially through what is called the Advanced Market Commitment, or AMC. And there are about 92 such countries or participants. Next slide, please. So, as I mentioned, the Act was established in April, and then in May, there was work that has started to define the rules of the game in a way. What would be the approach to the access and allocation? And the first thing that was discussed was what are some of the underpinning principles that would facilitate these processes? And they are listed here. There are 8 of them. The first one pertains to solidarity and the recognition that we need to join forces to tackle this. The processes need to have clear accountability lines, so have roles and responsibilities that everybody understands, and transparency around this so that trust can be maintained. It needs to be responsive to public health needs, and be characterized by equity and fairness. The products need to be carefully reviewed also in terms of pricing and efforts to be made that these are affordable. There needs to be a collaborative approach so that the strengths of all stakeholders are leveraged. And of course, they need to be, the products that are being allocated and distributed, they need to be safe, they need to be efficacious, and they need to have high quality standards. And after the regulatory processes that would enable this, they need to be paired with efficient procurement practices. Next slide, please. So now, moving on the allocation approach. This was driven by public health objectives, and the initial ones are to reduce mortality and to protect healthcare systems. We have seen that the virus, and we have also heard from previous presentations that the virus has affected some populations more compared to others. So initially, when we have been looking at the data, we already had sight on what are the high-risk groups, as well as the fact that in most pandemics and epidemics, healthcare workers are particularly exposed. So they need to be protected. And this is how this 20% threshold arose. As for most countries, an allocation equal to 20% of their population would be enough to cover the populations that I just mentioned, which would comprise the initially prioritized target groups. And I will also comment a bit more how this has shaped the allocation framework. Next slide, please. It is important to note that the process of global allocation is focused on distributing vaccines globally, but it is not a substitute and it's not a way of deciding the national allocations. That is something that the countries need to decide themselves, and they need to do this based on a national risk assessment. However, WHO has put guidance for countries on how this process should be driven, and this is the role of an expert advisory group. It's called the Strategic Advisory Group on Experts on Immunization, or SAGE, who looks at the available evidence and provides such guidance, and periodically also updates their recommendations based on emerging evidence. So they have produced a roadmap for prioritization of target groups. And if you will go into that link, you will see what are the recommended populations, which WHO strongly recommends to countries to follow. Next slide, please. So now for the allocation framework itself. If you remember the 20% considerations, this threshold has been used to separate a bit the phases of how the vaccine rollout should be thought through. It was foreseen, and in the beginning it was stressed that countries need to have an understanding of how much vaccine they will receive and how the process will unfold. And it was also stressed that every country was exposed and that the threat is ubiquitous. So everyone was facing a great challenge. So to distill this into an allocation approach, it was proposed that proportional allocation, proportional to the population of each country, would be adopted until this 20% threshold is met. So in other words, countries will incrementally receive vaccines to cover the same level of their populations. And once this 20% threshold is achieved, and it's considered that a baseline of protection is everywhere around the world, then further allocations would contribute, but other criteria may be taken into account. That would not mean that countries would stop receiving vaccines. They would still receive vaccines at each allocation, but there might be considerations based on threat and vulnerability, which are more linked to epidemiological criteria. And if you go at the in the links, you will see in the body of the allocation framework what are the indicators and the criteria proposed for this phase 2, which will be revisited once we approach that part. Next slide, please. What's also important to note is that the vaccines go to countries, but there is also a separate pot that is reserved for humanitarian settings who have these vulnerable populations and sometimes are in sort of legal, uncertain legal situations. This is not to disincentivize countries to take care of the populations that they are hosting. So the humanitarian buffer aims to be a provider of last resort to reach these certain populations. Next slide, please. Here are some numbers. They're the latest from the beginning of the week, so I don't think they're outdated already. But what's important to note is that vaccines have started to be distributed. They are reaching more and more economies, but it's always important to remember where we were very recently, where they weren't in all the countries. And it's important to keep this process and at pace so that we capitalize on all the efforts and great achievements that we have done and try to expand vaccination coverage as much as possible. Next slide, please. Next slide. And just the last slides now, I will give you an overview of the allocations that have been done so far through COVAX. The first one was more of a learning experience because of the very limited supply of available doses of the Pfizer-BioNTech product, and that was in the end of January. This was then followed by a more substantial allocation of the AstraZeneca products that are manufactured, as I mentioned, in 2 different places. Next slide, please. So here you will see how much we were able to cover with these allocations. And you will see that, okay, some countries are pretty much at the same level, but others have gotten a lot. So why is that? Is that equitable? And the answer to this is, has happened because of a flexibility that has been foreseen from the beginning in the allocation framework. And it is particular for very small countries where you cannot ship few products because of the minimum shipment size. So those amounts, while they seem big in percentages, they're not that big in terms of actual doses. And this is why, if you look at this graph, some countries have gotten more than others. Next slide, please. This is also explains the variation between the minimum and the maximum coverage. This is also, of course, linked to the different type of arrangements that countries have entered into COVAX. But what's to note is that we are still in the beginning. The percent of population that is being covered on average is still small. So we need to continue with this and to make sure that access is still enabled for all countries that want to get vaccines through COVAX. Next slide, please. This is a dashboard that is hosted on WHO website. And you will see here the global vaccination. The same dashboard will give you an overview of the number of cases, the number of deaths. So it's a good resource that while the information is outdated now, you can always go back and click on it and check. And you can also hover over a country and you will see for each country the situation. Next slide, please. So this is the last slide. It's again a recap of all the resources and the documentation and the dashboards that will give you a sense of where we are in this global allocation effort. Thank you very much.
All right, well, thank you very much, Iona, and to our other speakers as well. Thank you for really a tremendous amount of information contained within each of your talks. We have lots of questions. We don't have a lot of time left, but what I would like to do is go through as many of the questions as possible. I will select speakers to answer the questions, and if others would like to offer a comment, please feel free to do so. And then I would just ask that you keep your comments, keep your answers short so that we can get to a number of the questions. I would say that we've had a number of questions that have really wondered about the safety of the vaccines, whether or not they should even take a vaccine. And you know, looking back on nearly 300 years worth of vaccination science and technology that has greatly improved the survivability of infections around the world, I wonder if I could ask any of our speakers to comment on the principle behind the vaccination and why asking the question of whether you should take it or not is perhaps not the right question to be asking. Anybody like to take a shot at that? Oh, come on, speakers.
I mean, this is Miguel. I think that the important thing here is to look at what we know so far from these vaccines, and you know, it seems like they are all equally effective and certainly safe. What we're seeing is that these vaccines are extremely effective in terms of decreasing hospitalization and mortality. And that is what is most important, I think. You know, people can still get infection while having the vaccine, but the hospitalization rate and the mortality has dramatically decreased in the people that is vaccinated.
Thanks, Miguel. Yeah, I think that that's a really important point. You wind up getting a mild infection instead of a severe life-threatening infection. And actually, for many people who are vaccinated, based on the results, you won't get any infection at all. And so I think that there's no question, but after tens of thousands of patients have gone through these trials, that these vaccines are extremely effective at controlling the pandemic. We've had questions about the subcutaneous administration, and as Radek has gone through in his presentation, there is a problem with giving intramuscular injections in individuals who have bleeding disorders. Radek has offered a number of suggestions for how to take precautions to prevent bleeding. Clearly, if you have access to factor, that's the best way of preventing bleeding, or if you're on emicizumab, that should prevent any bleeding as well. But what about subcutaneous? What do we know about the work involved in developing a subcutaneous vaccine and whether or not that would be effective? Iona, are you aware of work on subcutaneous vaccines?
So there are a lot.
Iona, go ahead.
I was just going to say that there are a lot of products in development, and I think what would be useful is for me to put a tracker in the chat box so that you have an overview of what's in the pipeline.
Very good. Thank you. Johnny?
No, I was going to make the same comment that most of these are in the preclinical development stage. I'm not aware of any in the clinical space as yet.
Okay.
Glenn, if I can comment, I think that it's important to give our audience that the indication should be to get vaccinated right now, what we have, and not wait for a sub-Q vaccine to come out down the road. I don't think that is correct. So I think our recommendation is to vaccinate everybody. If they need factor, go ahead and do it. But vaccination should be done the way it's done right now because we don't have more data.
Okay. Thank you, Miguel.
I agree
Cedric.
with Miguel. Oh, sorry. Yeah, go ahead, Cedric.
Well, maybe, looking after many patients, with hematological disease, including patients with very low platelets and multiple problems. And these patients have been given the vaccine, by the intramuscular route without any bleeding problem. If you look at the size of the needle, if you look at the amount of fluid that is injected, it's really so small. We haven't seen any problem so far. So I'm not really concerned by the risk. It's not a big needle with a huge amount of fluid. It's a very small needle with a very small amount of fluid.
Okay, thank you, Cedric. We've had a lot of questions about various complications of hemophilia. This problem, that problem, prior infections, prior significant bleeding episodes. Can I ask our hemophilia treaters on the call to just comment on the fact that none of that is really relevant when it comes to getting a vaccine? Miguel, do you want to comment?
Yeah, absolutely. As has been already mentioned with the other speakers, definitely hemophilia is not a risk factor to develop severe disease. I think everybody's prone to develop an infection if you are in contact with somebody that is positive. But hemophilia is not a risk. But having said that, if a hemophilia patient has risk factors, definitely he could be at risk of having severe infections. I can tell you I've had many patients that have been hospitalized. Unfortunately, I've had deaths of patients with hemophilia, but they had other risk factors. They were extremely obese, they had respiratory problems. So definitely those patients have to be, could be considered at a higher risk. And that's what is important to know. Patients with bleeding disorders itself is not a risk factor. And they should be doing the same thing as everybody else, maintaining the guidelines and certainly getting vaccinated if they have access to the vaccine. But hemophilia itself is not a risk factor for developing severe infection.
Okay, thank you, Miguel. There have been questions about that are going to be difficult to answer. How long will immunity last after vaccination? What's the risk of reinfection after vaccination? How long after the second shot, if you get 2 shots, will full immunity be achieved? What can we say about how long immunity will last after vaccination? Can we say anything?
Glenn, my impression is, and I think you and Michael commented quite clearly that this virus is likely to be with us for a long time. Just like the flu viruses are with us for a long time. So my impression is that we may have to repeat the vaccination process on a regular basis, maybe not dissimilar to what we do on a seasonal basis with flu. We don't have data that shows how long it lasts. The preliminary data that we have suggests that people actually do lose immunity. There is also data that I've come across, certainly with the P1 variant, that people can be reinfected with the same variant, even though they might recently have been exposed to it. So those are some of the questions I think that will have better answers as the data begin to emerge out of this.
And the answer to the question after the second shot, when is full immunity achieved? The CDC has said 2 weeks is sufficient to provide immunity. What about children? And maybe this is a question for Iona. Where are we going with vaccinating children? How soon before we can actually start?
So I think this is a response that is also applicable to the other questions you had. We are in a stage where we are learning a lot. So it's difficult to have final answers without having the definitive science behind them. I think we are learning more and more, and there are studies that have begun to include children, but we need to see how these conclude and what are the results. For Pfizer in particular, if I remember correctly, they have already had done the research from 16 onwards. So the vaccine that is currently on the market, if I remember correctly, already encloses these populations.
Good, thank you. There was a specific question about polyethylene glycol, PEG. And as far as I know, the only 2 vaccines that contain polyethylene glycol are the 2 mRNA vaccines, the Pfizer vaccine and the Moderna vaccine. Polyethylene glycol is contained in some of our extended half-life clotting factors that are used within the hemophilia bleeding disorders community. And so if you do know that you have an allergy to polyethylene glycol, which is also present in a variety of foods and cosmetics, then those would be the 2 vaccines to avoid. But if you don't have that allergy, then there's no reason to avoid those 2 vaccines. There have been a couple of questions about the side effects of the vaccine. I'd like to ask our panel some of their opinions about that. Let me just start off by saying that if you vaccinate 10 million people, a certain proportion of those people are going to die within a week of the vaccination or get sick from some illness within a week of the vaccination. And it doesn't matter whether you vaccinated them or didn't vaccinate them, that's going to happen. And so the important thing is to figure out, do I have an increase in some adverse effect with the vaccine, or is this just part of what happens normally when you're administering millions and millions of vaccine doses? So with that in mind, I would like to ask about the recent reports over these last 2 days of the AstraZeneca vaccine and the risk of thrombosis that has appeared within Europe, and maybe start with Cedric on that. And then generally, how we should think about the adverse effects with the vaccinations. Cedric?
Well, thank you, Glenn. Yes, that's true. There have been 2 or 3 cases of pulmonary embolism reported in Europe. Things are currently being investigated, but as you said, clearly, the vaccine does protect against the virus, but does not protect against, the many diseases or many health problems that could occur among the huge number of people who are currently being vaccinated. So clearly, we need to know that, in Europe, nearly 500,000 people die every year because of pulmonary embolism. So clearly, every day people will die because of clots. So I think there is no causal or causality or causal relationship that can be established at this stage between these 2 or 3 cases and the vaccine. And I received some data earlier this morning. Clearly, one of the patients who developed PE in one of the countries clearly had multiple comorbidities, had PE in the past. So honestly, I don't see why there is so much concern about this for the moment.
Glenn, can I also comment on this, if that's okay? Just to give the access to the data and the situation, how we see it in WHO. I think we are all aware of the precautionary measure that a few countries in the EU have taken and have suspended use of a specific batch of AstraZeneca vaccine, which was distributed, and this was based on the rare blood coagulation disorders who have received vaccines from this particular batch. And our understanding is that this has been a precautionary measure, whilst the full investigation is still ongoing. And I think it's important to note that the European Medicines Agency, or the EMA, has the Pharmacovigilance Risk Assessment Committee, and that their position has been that the vaccine's benefits continue to outweigh the risks. So the vaccine can continue to be administered while the investigation is ongoing. At the global level, there is this body, it's called the Global Advisory Committee on Vaccine Safety, which looks at the safety signals and any such safety concerns that are linked to the COVID-19 vaccines. This body meets twice every 2 weeks and advises WHO on new safety signals. And they're currently also assessing the reports. I think as soon as we get more understanding of these events, there will be recommendations that will be communicated. But as you have mentioned previously on the vaccination concern, I think it's important to remember that vaccination remains very important. And as Cedric rightly said, it will not reduce deaths from other causes. It's really important to think in terms of causality. And so far, based on all the data that has been gathered, no deaths have been found to have been caused by COVID-19 vaccines. So these are the facts.
Okay, thank you, Ayana.
If I may, Glenn, to your first point, the incidence of those thrombotic events, if you look at the number of older people vaccinated so far with that vaccine, the incidence is not higher than in the general population if you run the calculation. So this speaks very much to your first point.
Okay, thank you. Quick question and answer on the chances of getting inhibitors, or if factors are taken prior to the vaccination. So this is something that we've looked at in detail in the hemophilia community. Is there a risk of inhibitors with childhood vaccinations? Who would like to take that question?
I can answer that. I mean, oh, sorry. Go ahead, Johnny.
No. You can go ahead. I was going to make a point that one should separate our hypothetical outlook at this in the context of danger signals, which is, I think, what vaccination is thought to bring to the fore, and the actual practical experience we have. Talking from our center's perspective, we've yet to see a scenario where someone is developing inhibitors as a result of the vaccination.
Miguel, anything to add?
No, I fully agree. I mean,
Another question, a couple of questions that have come up involve taking the vaccine if you're pregnant and risk of fertility problems with taking the vaccine. Who would like to address that? Maybe Iona, can you address that from a WHO perspective?
So to my knowledge, there is no data that would support any risk on fertility for pregnant women.
If I could add, most of the studies that I've seen would exclude pregnant women. So we probably don't have data, but I agree with Iona. We're not aware of at least any data that support the notion that the vaccination leads to infertility.
now, having said that, I mean, we are vaccinating pregnant women. You know, we don't have a lot of data, but it right now is optional. Female that are pregnant are getting vaccinated, and I'm sure there are ongoing studies also looking at that.
Okay, thank you. You know, a question for Iona, and it has to do with vaccine availability within various countries. And so this country has that vaccine, another country has another vaccine, a third country is working on getting a different vaccine. Can you maybe, I know it's complicated, but can you maybe give a simple explanation for how all of this comes about within individual countries, how a country selects a vaccine or more than one vaccine to have access to?
Sure. So what happens through COVAX is that countries sign up to receive vaccines. Depending on the model with which they sign up, some countries have opted for a model where they make a financial commitment when they sign up. So they get the possibility to opt in or opt out of a certain portfolio of vaccines, whereas others have decided that they will receive the vaccines that have been allocated to them. And it's important to note why I mentioned the WHO-EUL process, that all the vaccines that are allocated through the COVAX facility have gone through this procedure to assess their safety, quality, and efficacy. So the products that are allocated all of them need to meet this standard. What happens then is countries have also been asked to fill in a vaccine request form where they have expressed certain preferences. For example, some countries have said, we would only like vaccines that can be stored at 2 to 8 degrees. We would not want one that requires ultra cold chain storing. And then all this information and other such details. All this information is then brought together into an allocation tool. And there is a link to the slides that I mentioned that explains how this mechanism and how this software works. And what the software does is try to optimize what the countries asked for and what it is available. And this is how a product is allocated. When you have only one product to allocate, there isn't really much of a choice, unfortunately. So we are now in a situation where there is extremely limited supply. Hopefully, as the more vaccines become online, this will be there will be a wider choice, and this optimization can work even better.
All right, well, thank you for that. Cedric.
Well, just to comment that I think that in every hemophilia treatment center, if there is limited availability, I think that the patients who are at higher risk of developing severe COVID-19 should have access to the vaccine. So I think this is important. That's what we do in our center. For the moment, we have a limited access. So we try to be very selective and to identify the patients who, with hemophilia, who would be at higher risk of developing the disease. I think this is important, and that should be done everywhere.
Glenn, if I could just comment, just following through from Iona's comment, the vaccine access or acquisition strategy may well be influenced by the development of the COVID-19 variants, as it has happened in South Africa. We went ahead and got the AstraZeneca. When it arrived in the country, it turned out that the second wave COVID-19 virus was not responding to it. And in fact, we had to change the strategy midway. So my impression is that perhaps what the companies, at least what the countries ask for, may well be influenced what variant they have in that country, as it has happened in South Africa.
Thank you, Johnny. That's a very good point. And maybe despite what Johnny has just said, we've gotten a lot of questions about what vaccine should I take? And the simple answer to that question is the vaccine you have access to. That's the vaccine you should take.
Agree to that, and also not my previous answer not to be misinterpreted with the pregnant women. I think this is a conversation that the particular person needs to have with the doctor, because there is limited data on this, but there is also a risk profile that needs to be considered between the physician and the patient.
Good point. Radek, maybe one of the last questions for you. This is a question that is perhaps subject to interpretation. A person may test positive for COVID-19 because of the vaccine. So that can be interpreted in a lot of different ways, but maybe you can just explain if you're getting a test for COVID-19, will the vaccine interfere with that test or not?
Right. There are different kinds of tests for COVID. There is a RT-PCR test, which will detect the genetic material of the virus. There is a antigen test, which will detect the infection a little later when actually the virus replicated itself in your body to a appreciable degree. And there are also antibody tests, which may measure whether you have been exposed to the virus or to a vaccine. And you want that test to be positive following vaccination. You don't need to test for that, but I mean, shall an individual have a test done for anti-COVID antibodies 4 or 5 weeks or later after vaccination? They will have antibodies present, because that's the idea. These are the protective antibodies you want to develop against the infection with the actual virus.
Okay, and so if you get a test for the RT-PCR test, which is a nasal swab or a saliva sample, and you've been vaccinated, is there any risk that that vaccination is going to give you a positive result?
I don't believe that's the case. You don't get the virus is not administered via your intranasally, for example. So, yeah. So that shouldn't be the case. Also, the point on the alternative routes I was going to make earlier. So currently, all the vaccines in the clinic are delivered intramuscularly, and the other routes are tested only preclinically, including actually intranasal route. So perhaps this is something we may worry about in the future, but not now in terms of false positive tests.
All right. Well, I think we have covered many of the questions that have been asked. I thank our audience very much for all of the questions, lots of good questions, and I hope we've been able to cover them with good answers. I'd like to thank our panelists for great presentations and lots of accurate and quick answers on all of the questions. And with that, we will end and wish you well for the rest of your day.